All right, we're on to the next case with the 53-year-old male.
All right. This guy, he was diagnosed with Hep C about 5 years ago. He said he started with IV drug use about 12 years ago, and he used for about 7 years. And he also used cocaine and opioids. He smokes about a pack a day. He drinks maybe 1 to 2 drinks a week. His exam was normal. His ultrasound showed hepatomegaly. His elastography was F3. His vaccines were ordered. He has a history of type 2 diabetes, hyperlipidemia, chronic pain, migraines, and obesity. He's currently on aspirin, buprenorphine, Emgality, furosemide, Lasix, metformin, and verapamil. His BMI is 34.7. His platelets were 166. His glucose was elevated. INR is 1.0. His APRI was 0.6. Child was 5A. His MELD was 6. Iron was okay. His vitamin D is good. He is genotype 3. His viral load was 1.7. And the serum fibrosis is off from the elastography. This is showing F0 to F1. The rest, like I said, I ordered his hepatitis vaccines. And I don't think there's any interactions with his medications.
Great job again. Thank you, Gary. Does anybody have any clarifying question? And as always, we can always bring the case back up if you have to look at it again. All right, if you guys want to do the recommendations, go ahead.
Yeah, I'll just copy and paste what Kaylee said for the last case onto this one. Like, it's crazy, Gary. You got to you always do such a good job delineating the time course of exposure. So thank you for doing that. Another one that's you know, I'm sure this F3 is multifactorial. It's the diabetes, the obesity. You know, he's got that metabolic milieu that is so worrisome, and of course, drinking. You know, the worst thing for this guy is the multi-hit phenomenon. So he's got hepatitis in there. He's got alcohol. He's got obesity. That dangerous milieu in there that's doing nothing good for his liver. So I think your Maverick for 8 weeks should take care of him. He's genotype 3. He's not cirrhotic. But another one that's really progressing quickly if he's really only used drugs for a decade or so. And so a great time to treat him. He's another one where you have a lot of discordance between your two biomarkers with your elastography looking a little more pessimistic. Same exact advice for the last one. Follow him for a few years after SVR with Q6 month ultrasounds and eventually space it out to yearly. But hopefully as you get to know this guy better, you can really convince him that any alcohol is too much, and his weight is also a major cofactor going forward. So, and then I punt to Kaylee if she's got anything else.
No, I think Maverick for 8 weeks, or, you know, Epclusa for 12. Those are our two pangenotypics that would certainly, you know, they'd target his genotype. One thing I want to point out though, remember, so he's not cirrhotic, but remember, if we have a genotype 3 that is cirrhotic, you have to do that baseline resistance testing if you're planning to use Epclusa. So just throwing that out there. I know he's not right now, but, you know, just a reminder. Thanks, Gary.
Thank you.
Thank you so much. Do you have any other questions?
Did he used to drink more out of curiosity? Because it's a couple beers every other day. He seems like I don't know. I wonder if he ever was a heavy drinker or something.
Not that he offered, but it's hard to say.
I see his diabetes is not, you know, perfectly controlled. So, I mean, it's probably a lot to do with that and the extra weight he's carrying and, you know, the high cholesterol that's promoting all of this too. Like you said, metabolic milieu.
Yeah, I can't remember if you got his his med list. I can remember. Maybe get him on that, the Ozempic or Mounjaro or something, whatever those, those new cool weight loss drugs that also treat sugar.
Yeah.
Excellent. Thank you so much. Thank you, Gary, again. All right, Jennifer Boyd, are you still in here? I can't. There you are. I just see black squares, no faces. Okay, there you are. Perfect. Are you ready to do your case?
Oh, I forgot I had a case. I'm glad I'm here. I'm sure I saw the patient, so let's see who it is.
It's 32223. I'll share my screen. It's a
I'm so
44-year-old
sorry I
patient.
spaced. I'm glad I'm here,
Give me 1 second. Sorry, my dogs are nuts right now. Okay,
but we can't hear your dogs.
good. Is that good?
Yeah, that's good. Okay, so clearly I saw a 44-year-old Caucasian female with Medicaid. I wish I could bring this person into my mind. Anyway, she's known since 2017. She was this was back in the days where you had to be, for Medicaid, you had to be a F2 to get treatment. So she just got seen, but never got treated. She has used alcohol in the past, but not much, and does not use now. She's in a Suboxone program and is sober. She has her partner is female. Her risk factors were she used IV drug used a few times in her 30s, so 10, 15 years ago, but had used intranasally prior to that and since then. She first started using almost 20 years ago. She also had a non-professional tattoo in 1999 and some subsequent to that, and had one previous partner with Hep C. I put fairly unstable here, and I'm not sure, I'm sorry that I'm spacing on this, but I don't have a reason to think this person will be relapsing. She does have depression and anxiety and is on Wellbutrin and ibuprofen. She's also on lamotrigine, which was one that I was a little curious if there would be any issue with that. Depo, and she does that, I'm assuming she does that to control periods because she is not at risk for pregnancy with her current partner. She's on Suboxone and Topamax. She's been immunized to hepatitis A, but not to Hep B, and we are now starting vaccination in clinic when they come in, so we'll see if she got vaccinated. Her CBC was normal. INR was 1. Her LFTs were good. She had an APRI of 0.19, child Turco-Pugh class A, and a MELD score of 7. Iron studies were normal. Vitamin D I started her on, I'm sure. HIV negative, genotype 1A, and excuse me, her serum fibrosis markers had her at an F0. So I'm glad I have my notes here. Struggling with sobriety, I think because of her living situation, but really eager to be treated. Obviously I discussed at her first visit and would continue to discuss with her that it's a one-time deal as far as her insurance goes, and to really reinforce the importance of her not going back to using. That's the story. Mavorite or Eclusa seem like they would be appropriate given her genotype.
Thank you so much, Jen. Does anybody have any questions about this patient? All right, we can go into the recommendations.
Thanks, Jen. It's Kaylee. I agree, either 8 weeks of Mavorite or 12 weeks Epclusa. No preference with what you've given with this case. And just to recall, this is a 44-year-old female. of childbearing age. I know that she's not at risk for pregnancy. She's on depot, but just remember that drug interaction. If she were on an ethinyl estradiol containing contraceptive measure, then that Mavorite would be contraindicated. So she's not, but just again, just kind of throwing out that piece of information too. But otherwise, yep, either one in her case.
Hey, Rachel, is the big categories we worry about with all of our DAAs are medications that are related to, anti-seizure, anti-arrhythmic, stuff like that. With the either the Topamax or the lamotrigine an issue for her? Or are they the ones that are safe?
Yeah, those ones are going to be on the safe side here. So the ones we worry about from the anticonvulsant medications are going to be your carbamazepine, as well as the oxcarbazepine, the phenytoin, and the phenobarbital. Remember, those are all enzyme inducers, so you get subtherapeutic levels of all the DAAs. There's no safe DAAs as far as concomitant administration there. So those are your four. But the Topamax here and the Lamictal, those are both good to go as far as the DAAs go. I don't have a concern with either Mavorite or Epclusa in this situation.
Excellent.
And the only other thing I'm going to mention for those on the call who haven't been with us since 2000 and whatever, when fibrosis restrictions were a thing, the fact that this lady tried to get care but was turned away due to not having enough fibrosis indicates this was before 2019. And just as a little history, remember we when these DAAs first came out in 2015, 16, the insurers really wouldn't let us treat people who had less than F3, F4 fibrosis. And then over time that decreased to F2 or greater fibrosis. And I was thankfully gone. And really the bummer part about this is it ignored, number one, the sometimes discordance between extrahepatic manifestations and your fibrosis score. Yes, it said, okay, your liver's not very sick, but that doesn't mean that you aren't sick with some other A, symptom, or B, extrahepatic manifestation, number one. Number two, it's just discouraging to the patients and ignored their well-being. And also ignored transmission. So, this concept of, treatment as prevention was something that wasn't really being validated back then when we were only treating people with aggressive fibrosis. So anyway, good stuff. So happy we live in 2020. What is this? 2020 something blank. I can't remember.
And to toot the echo horn, I mean, I might be wrong, maybe Dr. Feinberg or Dr. Gilfush, but I think that it was partly echo and the advent of primary care providers getting support for treatment that helped lead to the people to see the light and change the eligibility. Dr. Rexroad agrees with me. Yeah. So go echo, go echo.
That's excellent to hear. Oh my gosh. Yeah, Mitra's loving it. Thank you. And I'm really happy that's what this is about. So that's really nice to hear. All right. Any further questions, Jen? Are we good? Good. All right.
Good. Thank you.
Thank you very much. All right, Dr. Feinberg, are you ready to do your presentation?
I am.
Perfect. Would you like me to share your slides or would you like to do so?
It's fine if you can do them.
Absolutely. I'd be happy to. Give me one moment. All right. Can you see that okay?
Great.
Great.
Okay, folks, I'm going to talk about Hep C in women of childbearing potential today. Next slide. So, as in most everything relating to hepatitis C and the drug epidemic, you never really need to draw the square like I did around Central Appalachia, but there it is. We have the highest rate of maternal Hep C in the country. We and our surrounding states, right? Southern Ohio, Eastern Kentucky, Northeastern Tennessee. That kind of say it, actually. Next slide. So here is a study that looked retrospectively at Hep C in pregnancy over a 10-year period. And The overall rate of births to women who had hepatitis C doubled over this decade, and it was highest in Indigenous women, Native Americans, and in white women. So on the left, you can see the overall graph. On the right, you can see by race and ethnicity. And the next slide should show, here it is, by education. So without a college education, you see a huge increase on the left. And on the right-hand side, you see both remote and adjacent rural areas, also way outpacing women who live in urban environments. Next slide. So that pretty much describes West Virginia, folks. So here is the current recommendations for Hep C testing, and comes from two different sources, from the CDC and then from the combined American Association for the Study of Liver Disease and Infectious Disease Society of America. So we should be screening at least once in a lifetime everybody who's 18 years old or older. And I won't even say the exception because that's not West Virginia. And in addition, we should be screening all pregnant women during each pregnancy because, of course, you can always acquire Hep C between pregnancies. And prenatal Hep C testing should really be part of just routine prenatal care entirely. Next slide. So here is another retrospective study. This is one that addressed adverse pregnancy outcomes and comes from the National Inpatient Sample Study over the period from 2012 to 2018. And you can see that there were over 50,000 pregnant women with Hep B and over 130,000 with Hep C. And for hepatitis C, this sample was 82% white, 80% on Medicaid, 14% delivering in a rural hospital. And if you looked at maternal mortality, length of hospital stay, the incidence of preterm labor, all of these showed highly statistically significant increases. And you can see how many zeros there are in that p-value compared to women who did not have hepatitis C. Next slide. So there is, of course, a risk of vertical transmission from pregnant woman to newborn. We think that if the mom only has hepatitis C, that the overall rate's about 6%. And really, if the viral load is really low, then this just doesn't. Oh, hang on a second. I have to deal with that. Okay, sorry. Let's see. What happened to my slides?
They're still here, Dr. Feinberg.
Oh, wait. But I can't see them. Hang on a second.
No worries.
Something happened when I said on that phone that I would call them back. Okay. Why can't I see them?
Can you see me or the?
Wait, let me go to the Zoom button.
Yeah.
But now I got it. Okay.
Perfect.
Something about the phone calls goofed that up. So the maternal viral load correlates in this setting of monoinfection with the risk of transmission. So you don't see cases with very low viral loads. And then, as the viral load increases, especially over 6 logs, which is over 1 million, then there is a significant increase in the MTCT, mother-to-child transmission. And in this study, genotype 1 was more likely to be involved in vertical transmission than other genotypes. However, in women who have both HIV and Hep C, the overall risk of vertical transmission just about doubles. And there are specific risk factors There's prolonged rupture of membranes, so that's more than 6 hours, or any kind of procedures or events that could expose the infant to maternal blood, like these are not cases where you should do this internal fetal monitoring. And of course, maternal injection drug use is a significant factor. Next slide. However, the mode of delivery does not affect transmission. Doesn't matter whether the birth process is vaginal or cesarean. And unlike HIV, breastfeeding is not a risk for mother-to-child transmission, except where, there's exposure to blood, cracked nipples, and of course, where there's also HIV co-infection. Next slide. So we don't entirely know when vertical transmission occurs. In general, the data seem to indicate that it's primarily at delivery or shortly before delivery. But there's been some recent data that seems to indicate that it might occur earlier in the pregnancy, somewhere between 25 and 36 weeks. So that's the third trimester. And of course, what this implies is that if you want to intervene to prevent vertical transmission, then you clearly would need to do that before delivery. Next slide. So here's are the guideline recommendations for Hep C management of women of reproductive potential. So of women who have known Hep C, then obviously what you want to do is offer curative therapy before they get pregnant. But if that has not occurred, then counseling during pregnancy is important. First of all, women should know that there is this small but measurable risk of vertical transmission. And the key thing really is this need for ongoing follow-up and testing for both the mom and the infant. And this is particularly important because many women who have acquired hepatitis C through injection drug use, tend to sort of drop out of medical care after they deliver their babies. And so there's, it's really important to encourage them to stay connected so that we could follow them and follow the infant. And of course, there's always the possibility of spontaneous Hep C clearance. So, those are important issues. Next slide. And then, of course, if you have a pregnant woman who has HIV, then they have to receive all the prenatal and intrapartum care that would be appropriate for their individual obstetric situation. As I mentioned before, there's no known intervention that will reduce mother-to-child transmission. So monitoring the viral load and liver functions are important. And you want to assess, of course, the viral load will help you assess the potential risk of vertical transmission. And one of the things that is a complication of pregnancy is, especially women who have pruritus or jaundice, you have to be thinking about the intrahepatic cholestasis of pregnancy, and then appropriately evaluate them with monitoring their transaminases and serum bile acid levels. And then, of course, if they have cirrhosis, they need to be counseled about the increased risk of adverse, both maternal and perinatal outcomes. And, these are women who really need to be monitored by an obstetrician who's experienced with high-risk pregnancies. Next slide. So as I mentioned before, breastfeeding is not contraindicated because Hep C is not transmitted in breast milk, except if there's a situation in which there might be exposure to maternal blood, like the nipples are cracked or bleeding, or if that woman also has HIV. And then women should certainly be reevaluated after delivery to see if they've spontaneously cleared, which happens in about 10%. Next slide. So the birth score, the West Virginia birth score, and this is the actual picture of the from the website, has been updated. And in the next slide, and of course, this is a screenshot, so it is tiny, but in February 2020, the form was amended to include maternal hepatitis C. And I circled those in red. It says, is infant diagnosed with NAS? And does the mother have hepatitis C? Yes, no, unknown. And this is the first step toward what the Department of West Virginia Department of Health and Human Resources wants to be able to notify the care providers who are going to be managing these infants and children, that, you know, so that they get monitored appropriately if their mothers have had hep C. And you can do that through viral load testing before a year of age, or you can do that with hep C antibody testing after 18 months of age. And because by that time, the child will have cleared maternal antibody. If you look at antibody status in the child before 18 months of age, then, you know, it might just reflect what the mother's status was. Next slide. So, should we treat women who are pregnant during the pregnancy? And there's arguments pro and con. I think a primary one is that we cured women during the pregnancy, then we wouldn't have to be concerned about the postpartum loss to follow-up. And this is a period where they're engaged in care and hopefully getting prenatal care. Of course, this might decrease mother-to-child transmission and really, you know, protect children who can develop cirrhosis, actually, and at an earlier age than children who acquire hepatitis C through other routes. And surveys have indicated that the majority of women with hep C are interested in hep C treatment, especially if it could decrease the mother-to-child transmission. And of course, the arguments against treatment during pregnancy is we don't have a lot of information yet. There was a small study done at the University of Pittsburgh that's been published where about a dozen women got treated during the last trimester of pregnancy and was tolerated pretty well. But that's not a lot. There are some providers who are offering curative therapy to women during pregnancy with, you know, appropriate understanding that this is not an FDA approved indication. You know, cost effectiveness is yet another issue in the argument against treatment. Next slide. So this has been evolving. And as I said, there are providers who are offering treatment during pregnancy. I think this is primarily happening, to my knowledge, in New York City. Ideally, of course, we would like to have women cured before they get pregnant. But the guidelines are starting to say you can consider treatment during pregnancy on an individual basis after a frank discussion about potential risks and benefits. And if you look at the bottom under the references, then number 2 is Tatiana Kushner, and she is a hepatologist in New York City who has really been promoting the treatment of women during the 3rd trimester of pregnancy. Next slide. So there is a study. We were going to do this here in West Virginia, but the lawyers told us no, we couldn't. So we got X'd out of it. We were one of 7 sites. Now there's just 6 sites left. And the acronym is STORK. And it's a study of sofosbuvir, velpatasvir, or Epclusa. And this is, again, you know, starting well after all the organs have been formed, because at the beginning of the 3rd trimester. And the closest site to us is Pittsburgh. And this started just a couple of months ago. I think the first mom was enrolled at the end of November or early December. So, and the plan is to treat 100 mothers, pregnant mothers. So we'll get, it's observational though, obviously it's not randomized and it's not controlled, but we will, compared to what we know from the natural history, I think have some more sort of concentrated data on this situation. Next slide. So really, in this patient population, harm reduction is a very important consideration from preconception all the way through postpartum. You know, there are a number of significant issues that these women face: stigma, behavioral risks, access to syringe services, harm reduction strategies, prenatal care, testing and longitudinal follow-up for the baby, getting the mom into Hep C treatment after delivery, and preventing reinfection. So there's an entire range of ways that we can offer services to women of childbearing potential who have hepatitis C. And I don't know if that's the last slide. Let's see, next slide. That is the last slide. So I'm happy to take any questions. Here I am in living color.
Dr. Feinberg, that was great. Thank you so much. I have to go in a few minutes, but my question is about pediatrics. So does anybody know how many children who were born to Hep C positive mothers are being lost to follow-up?
So I can't tell you how many are being lost, because of course that's a negative.
Right, they're lost, right? Yeah, right.
You don't know what you don't know.
Yeah.
But the Bureau for Public Health has estimated, given the number of women with Hep C that we're aware of childbearing potential, and given a 6% vertical transmission rate, we think that there are probably somewhere around seven babies born annually with Hep C in West Virginia. Now, as the HIV epidemic keeps moving among people who inject drugs, that will, of course, sort of change the equation, because that essentially doubles the risk. So that's what that's their preliminary kind of guesstimate as to what they want to, you know, what we're facing as a public health issue. And I think the important thing is, of course, if we could really screen everybody over the age of 18 and identify women who have Hep C before they get pregnant, you know, that would obviously be, you know, the best of all possible worlds, because we could cure them then before they conceive, and this risk would go away. But I think the other important thing is, and I think the Bureau for Public Health is sort of struggling with, what is the best way to connect these babies and the maternal Hep C information and put that in the hands of the provider. And, you know, HIPAA is the block here, because you're like sharing the mother's information with the, you know, with somebody else. But so they're trying to work through how to do this. But I think it's really important for family care providers and pediatricians in the state to, to be aware that this is an issue, and, to be screening children who conceivably have had this exposure. And as I said, you can screen after 18 months with antibody, but you can screen before a year of age. If you've got a mother who acknowledges risk or acknowledges that she has hepatitis C, you can screen before a year of age with RNA PCR. There's not an enormous advantage to screening early because the FDA, while we have a number of drugs approved for use in children, the youngest it goes down to is 3 years of age. So even if you diagnose a baby, say at 11 months, you're still going to have to wait 2 years to treat that child. But luckily, typically the progression of liver disease in these children is not particularly fast. And, if you identify them and then start treating them when they turn 3, they shouldn't have really suffered any long-term significant liver damage. The real issue is in missing it. And then, they're 25 years old and they do have cirrhosis because they've been infected for 25 years. So, those are the public health perspectives. That was a good question, Jen. Thank you for asking that.
Yeah, thanks for everything.
Thank you so much.
Hey, Dr. Feinberg.
Uh-huh.
Dr. Feinberg, this is Jessica Haas here with the PCA. One thing that I have experienced in looking in the neonatal data portion was that we see a lot of unknowns when a mom delivers. You see that quite a bit. And I feel like that we need to do a little bit more education, or the importance of knowing that we shouldn't have a mom that delivers that we don't know. Because of course that trickles down for the infants. And I think that is something that it seems like through the years that I've done neonatal data work, that is an issue. And it's becoming a problem.
Yeah, you're totally right, Jessie. This is a really significant problem. And what we really need to do is to get people who are providers who are rendering prenatal care to just add hepatitis C screening, to the panel of tests they already do, right? What's the acronym? It's I'm forgetting the acronym for all those diseases that you're supposed to screen for. But hepatitis B and HIV are already part of routine prenatal care, so it's just a matter of adding Hep C. Torch, yeah, thank you. Torch titers, right? Toxo, rubella, etc. So CMV, herpes. So we really need to get providers to step up their game to do that. So that way we know, the ideal thing is, right, you screen people as soon as they turn 18, or whenever you see them after they've turned 18, because once they come in for prenatal care, then it's a matter of, are you willing to treat a woman in the 3rd trimester of pregnancy? And is that woman, or women plural, are they accepting of that, given that it's not an FDA, approved indication? So, like all things medical, right? The sooner you know, the better it is for the woman, and in this case also for her baby. But you're really right, Jessie. This is what we got to do now. This is what the public health imperative is.
Thank you. Thank you so much, Jessica. And Dr. Rexroth, go ahead. Thank you.
Well, thanks. This is more of a comment, but just along what you're saying about the public health perspective. I do family planning clinics at a couple of different health departments. And, there are CLIA waived finger stick tests for HIV and hepatitis C. If we could get somebody to fund those, that we could get them into the health department clinics, we could do them on the women who come in for their family planning visits. You know, and we would catch them early. But I don't know how you get the money.
Yeah, no, that is a very valuable and important comment, Carmen. We could do that. And the problem is, and I've priced this out for grants that I've applied for, and it comes out to about $17 a test, you know, using the best possible cost, you know, saying it's for research. Often they'll give you a break. It's for research and not for care. At $17 a test is a lot of money when you're talking about a lot of people to screen. So yeah, I would love for that to be part of things. Now, the county health departments can, at no expense to the people coming to them, can send a blood test to the state lab, but it's not, you know, it's not a finger stick. It's, they draw blood and they mail it off to the state lab.
Right. We do that, or we try, but yeah, it would be so nice to have that, to be able to discuss it while the woman is there.
You know, there is even better, something better than the finger stick tests, which all have to be confirmed, right? Because all the rapid test for Hep C tells you is that that woman has antibody. So they could have, you know, had Hep C and cleared it. Could be one of the 20 or whatever the real percent is who clear spontaneously. But Cepheid, which is a diagnostic company that makes the equipment and the, what's the word? The
Reagents, or
thank you. The reagents, they have point of care testing for a number of diseases, including COVID and HIV, and they've got a great test for Hep C that in 50 minutes, so less than an hour, can tell you if that patient has Hep C RNA, so if they're chronically infected. And that company has been previously not real excited about getting FDA approval in the United States. It's widely used in Europe, Australia, Canada, New Zealand, you know, other resource-rich countries. It's widely used, but we had a meeting last year where the public health labs, the Association for Public Health Labs, and the FDA, and a number of people who are expert in hepatitis C disease had a meeting that was hopefully going to move. The point was to help move the FDA along for the requirements for approving this. And the FDA did subsequently modify their requirements. And Cepheid says now they will be applying for their Hep C test. But, you know, then you as a clinic, or I can't imagine the health departments would have money for this. No. But if a clinic that already has that platform or is willing to invest in that platform, you would get, you would have an answer to, does a person have chronic hepatitis C in less than an hour? And that there's really a lot of value in that, right? Because you don't have to bring them back for a second blood test. And if they can wait an hour, they'll know the same day. So, you know, you can then take the same approach that we've been taking to HIV, which is to institute therapy as soon as possible, you know, including same day starts. So hopefully we'll get there. You know, it is, however, like everything, costs money.
Thank you so much. Great questions and comments and presentation, Dr. Feinberg. Does anybody else have any further questions before we do our closing remarks?
One more question.
Go
Hey,
ahead,
Dr. Feinberg, it's Kaylee. Thank you so much, because you're always so informative, and I really appreciate you giving this, because I can't think of anybody better to give this than you. I really just wanted to pick your brain. I had a question about how you would approach a patient that has already been started on treatment and then finds out that she's pregnant. would you, we have such succinct courses now. Would you, I know there's probably not guidance or data, but have you seen any case reports or what would your approach be?
I think here's the issue. Probably by the time, if someone's already getting treatment, right? And by the time you miss a period and can confirm a pregnancy, you're probably 6 weeks into that pregnancy. So you're half the way through the first trimester with when organs get formed. So I think what it's really ethically appropriate to do at that point is to have a discussion with the mom about, whether they want to stop treatment and restart at a later point, either in the third trimester or after they deliver, or whether they're willing to take that risk and go the other, and continue to expose the fetus to the other half of the first trimester of organ formation. I don't think there's a one size fits all, just like treating women in the third trimester of pregnancy, which is clearly being done by Dr. Kushner and others. I think it's a matter of discussing the potential risks and the potential benefits and supporting the mom in whatever decision she wants to make. I think in this setting, even for a Medicaid insured patient, I think it would be, I don't think it would be hard to convince Medicaid to let that woman, get a full course of treatment if she decides that, she doesn't want to continue now. Everyone's always worried about what Medicaid will do, but I actually have found them to be reasonably receptive to these kind of difficult situations.
Thank you. Yeah, thank you so much. I had a patient not too long ago that had been on about 2 weeks of Mavorite. Rachel can correct me if she's still on here, and it was a little bit longer than that, but had really just started and found out she was pregnant. And then we had actually opted to hold her course and then plan to restart. Medicaid patient, and they were cool with that, just holding it and then continuing therapy after she delivered. And interestingly, her viral load's already undetectable. So
Right.
now we're going to just follow her and then just see if maybe, hey, that short course and that, pregnancy and, maybe she's just cleared and she's good to go. But yeah, thank you. I just really wanted your insight.
No, you're welcome. And you know what? I think whenever there's some situation or circumstances that means that someone's going to get less than the prescribed course of therapy, I think what you did was exactly what needs to be done. Is you always need to snag a viral load, because we know that people can clear in much less than 8 or 12 weeks. And so, if you can demonstrate that, and then, subsequent monitoring confirms that, then, God bless, that's great. Cure in 2 weeks. I love that. John, did you want to ask a question too?
No, actually, Kaylee's on my machine here. So
Oh,
My cell phone stopped working. So I ran out to finish the call. But thank you so much, Dr. Feinberg.
that's so
Okay.
awesome. I 2 weeks of treatment. That's
right. But we've seen that. I mean,
for sure. Yeah.
remember that in the we don't do it anymore, but in the early stages of developing these new drugs, we used to check a viral load at 4 weeks. It was called the EVR, early virologic response. A lot of people cleared in 4 weeks. So, it happens. And it's probably related to viral load. Probably the people with a viral load of 30 million aren't going to clear in 2 weeks, but people with much smaller viral loads, probably that's really manageable. It also goes to show you that I shouldn't say all, but it goes to show you that many drugs that wind up getting FDA approval are probably over treatment. because drug companies tend to be very conservative about the dose and the number of times a day that a drug is administered. And it's only after drugs are on the market for a while that we say, oh, really, this drug has an intracellular half-life of 18 hours. We really do not need to give it 3 times a day. So, you do that retrenchment after, the drug's already on the market. But I mean, that happens a lot. If you think back into our first HIV drug, AZT, we used to give people 2 grams a day. And we used to give it every 4 hours. And now if you were going to use AZT, which we really don't anymore, you would be giving 300 milligrams twice a day. That's really different than 2 grams in a day. So, that's part of the world of drug development. So it may be that you don't need, for most people, 8 weeks of Mavyret or 12 weeks of Epclusa. Maybe for most people, they do fine with somewhat less. But, you're stuck with what the FDA approves. Anyway, thank you, everybody.
Thank you so much, Dr. Feinberg. It's been a great discussion. We really appreciate it. All right, just one announcement. Our next session will be January 26th with Dr. Gilfus, and he'll be discussing ticks, bite prevention, and natural history. During our survey with participants, they're really interested in expanding into Lyme disease.